Now we have a 45-minute session on the topic Management of Hypoxic Respiratory Failure in Late Preterm and Term Neonates. We are much obliged to have Professor Ramgasamy Ramanathan to lead this session. He will be joining us online. We also welcome Dr. Srinivas Ayar, who will be moderating the session.
Professor Ramgasamy Ramanathan, Professor of Pediatrics, Division Chief of Neonatology, and Director of NICU at Keck School of Medicine of the University of Southern California. His areas of special interests are surfactant therapy and oxygen toxicity. He is the recipient of numerous awards, including the Lifetime Achievement Award from National Neonatology Forum in the year 2017. With great pleasure, we welcome you, sir.
Thank you, and good morning, everybody. I was worried that I don't know what I did to Dr. Manoj. I've been nice to him, but he put me to follow after Dr. Satyan after such a great talk. I'm going to try my best. But in fact, actually, his talk has helped my talk to go smoothly, so I can even go faster and have enough time for question and answers. So my task is to talk about hypoxemic respiratory failure management in late preterm and term neonates. I'm not going to focus on preterm babies. I have nothing to disclose with respect to today's presentation. First thing, let's make some simple things clear. What is hypoxemia versus hypoxia? In fact, the title on the program says hypoxic respiratory failure, but I'm actually going to talk about hypoxic respiratory failure. So hypoxemia talks about low oxygen tension in the blood, low PaO2 or low saturation, whereas hypoxia refers to low oxygen supply to a tissue or organ. And I'm not doing any hemodynamics today, so I'm mainly focusing on hypoxemic respiratory failure or HRF. This is my cartoon. You have seen Dr. Satyan's infographics. I'm nowhere near that. I do something like this when I teach my fellows in the conference. So you need to look at the oxygen tree. When you're breathing room air, the PiO2, partial pressure of inspired oxygen at sea level, is 760 minus 47 times the FiO2, which is about 150 millimeters of mercury. As it gets into the alveolar side, the uppercase PaO2 is about 100 because you have PCO2 there. All gas pressures has to be equal. It cannot be more than 760. So it becomes 100. And then when the blood coming from the pulmonary veins, pulmonary artery, or mixed venous PO2 is about 40. So it picks up the oxygen, and then by the time it gets to the arterial side, the PaO2, small a, partial pressure of oxygen in the arterial blood is about 80 to 95. So the gradient, AA gradient, uppercase A, PaO2 minus PaO2, is usually about 5 to 20. In very healthy babies, it's 5, but most of the babies have 10 to 20 difference because of the physiological shunting, and that's the main reason, and dead space. So let's talk about hypoxemic respiratory failure and or PPHN in newborn babies. The overall incidence, somewhere between 2 to 4 per thousand. Sometimes it can be 2 to 6 per thousand. The problem with this disease is it's high mortality, 5 to 20% mortality. And if the babies survive, they have a much higher incidence of adverse neurological outcome, 25 to 35% in some studies. Before I move on further, I want you to think about two things. When we talk about pulmonary hypertension, is it pre-capillary pulmonary arterial hypertension or post-capillary pulmonary venous hypertension, or so-called passive pulmonary hypertension? And you want to know that because what you do here, pre-capillary, should not be doing it on post-capillary. Let's look at some of the common cause for pre-capillary pulmonary arterial hypertension under development. For example, oligohydramnios, induced pulmonary hypoplasia, or diaphragmatic hernia. Maldevelopment, like idiopathic PPHN, premature close to the ductus. SSRIs, selective serotonin reuptake inhibitors. Previous studies have shown that there is an association between mother taking SSRIs during pregnancy and pre-capillary pulmonary hypertension, but there are now recent data suggest that it may not be a major factor. The fourth thing, which is very important, Dr. Satyan covered a lot about avoiding hyperoxia. So if you cause hyperoxia iatrogenically, which is most of the time when we give supplemental oxygen, it does produce reactive oxygen species, produce hydrogen peroxide, peroxynitrite, and isoprotein generation from the arachidonic acid. All are very potent pulmonary artery vasoconstrictors. So if you give too much oxygen, you're going to cause pre-capillary pulmonary hypertension. You can use pulmonary vasodilator to treat this condition. But if the baby has post-capillary or pulmonary venous hypertension, for example, in a baby with left ventricular dysfunction, secondary to asphyxia or hypoxia, diaphragmatic hernia, the left ventricle is not fully developed, so it doesn't work well. Pulmonary vein stenosis, either congenital or acquired pulmonary vein stenosis. For example, now babies with severe BPD, a high incidence of acquired pulmonary vein stenosis. So we always, when you screen for BPD and pulmonary hypertension, you also want to look at the pulmonary veins. Hypoplastic left heart syndrome or critical coarctation, mitral stenosis, any obstructive lesion on the left side will increase the pressure in the left atrium, pulmonary veins, and produce pulmonary venous congestion and pulmonary venous hypertension or passive pulmonary hypertension. If you use vasodilators in this case, for example, if you give nitric oxide, they're going to get worse because you're going to increase more blood flow into the lung and it cannot get out through the pulmonary vein into the left side of the heart. So be very, very careful to use vasodilators in babies with passive pulmonary hypertension. So when we talk about hypoxemic respiratory failure and PPHN, is basically, remember, all babies, fetuses, or have physiologically their pulmonary hypertension. So from physiological state, they don't transition well, they end up with persistent pulmonary hypertension. They act like they're still fetuses after birth. It happens in about 10% of all neonates with respiratory failure from what variety of causes. Impaired pulmonary vascular adaptation during early neonatal period. There are multiple other causes I'll talk about in a minute. And there are some genetic factors, corticotropin releasing factor mutations. Reversibility, and we don't know what the impact on adult pulmonary disease in a baby who had pulmonary hypertension as a newborn. Are they at high risk for development of pulmonary hypertension as an adult or even as an adolescent? We don't know. We don't have much data on that. So again, this is Dr. Satyan's cartoon. I use a lot of his infographics. So we look at congenital causes, diaphragmatic hernia, CPAM, cystic pulmonary airway malformation, alveolar capillary dysplasia, surfactant protein defects, trisomy 21, thromboxane 4 mutations, or inborn metabolism, or cardiac defects. Most of the time, we are dealing with acquired conditions. Meconium aspiration syndrome is a classical example of a baby developing hypoxic respiratory failure and pulmonary hypertension. Asphyxia, sepsis, TTN in severe cases, pleural effusions, Ehrlich syndromes or RDS, classical RDS or ARDS. So how do we grade the severity of hypoxemic respiratory failure? So this is using oxygenation index, which is very typically used. Mild, 0 to 15. Moderate, when oxygenation index is 15 to 25. Between 25 to 40, severe. If the oxygenation index is more than 40, very severe. Most of these babies end up on ECMO. One of the criteria for putting a baby on ECMO is an OI greater than 40. One of the criteria for putting nitric oxide, OI greater than 20. And all of you know how oxygenation index is calculated. The problem with this oxygenation index is you need measurements of PaO2, post-ductal PaO2. Most of the studies used post-ductal PaO2 in the OI calculations and prediction. So we, a few years ago, looked at, and the others also published similar data, on using oxygen saturation index. So here, we use FiO2 times mean airway pressure times 100 because it's an index divided by pre or post-ductal saturation, SpO2. And based on our data, which I'm going to show in a minute, Between 0 to 6, OSI considered as mild, 6 to 9 as moderate, 9 to 12 as severe. Any OSI greater than 12 is considered very severe. So we looked at a correlation between oxygen saturation index and oxygenation index in babies with hypoxemic respiratory failure. One of my former fellows currently is a neonatologist in Phoenix, Dr. Hemananda Muniraman, and Dr. Bini Wali, and my associate. We published this paper in 2019. So we looked at 220 babies, 190 preterm babies, nearly 1,500 samples. Here is a log transformed OSI on the y-axis, OI on the horizontal x-axis. And this is the regression equation. And this, you can see a very good correlation between OI and OSI. So how do we translate this data into clinical? So here is clinically important oxygenation index. When the OI is 5, your oxygen saturation index is about 3. The 95 confidence interval, 2.56 to 3.62. OI of 10 is about 4.5. 15 is about 6. 20 is about 7. OIS of 25 is 8.7 or 9. 40 is 11 or 12 or 13. So OSI is nearly half of OI up to 15, and then nearly 1/3 of OI above 15 because the shape of the sigmoid shape of the oxygen dissociation curve. So it's very easy to look at it and say, okay, I'm going to start a baby on nitric oxide because my OI is 20, but I don't have a PO at this time. What can you do? If you have a saturation and you calculate the OSI, that value is between 6 to 9 or 6 to 8, probably baby will meet the criteria for hypoxemic respiratory failure. In the SYNERGY study, which is a clinical inhaled nitric oxide research group study published by Rees-Clark et al., they show, they also, how do you define? They also said if there is pre-ductal, post-ductal differential oxygenation, some books say, or some people will say difference of 5%, some use 10%, difference between pre and post. Again, if there is a difference between pre and post, you can say, yeah, there is pulmonary hypertension, or there is a right to left shunt, mainly through PTA. If the baby is shunting also to the PFO, you may not find any difference between pre and post. So presence will help you. If it is absent, it doesn't rule out that the baby is having a right to left shunt. Or other definition they used in the study of inhaled nitric oxide for late preterm and term babies is do 2 desaturation events in a 12-hour period. That is saturation dropping below 85 events occurring within 12 hours of observation or monitoring. Nowadays, most of you are using functional echocardiography, which helps a lot if you use that. Here is looking at the duct, classical 3-finger sign. The first one is duct, the middle one is left pulmonary artery, this is a right pulmonary artery on the parasternal short axis. Here is the aorta, here is the main pulmonary artery. And here with the bidirectional shunt, sometimes you may not be able to see this in parasternal short axis. You may have to go to ductal view, the suprasternal, especially when all of them are blue, you know that baby has right to left shunt. With oftentimes this baby is a bidirectional shunt. During diastole, they shunt right to left, and during systole, they may shunt left to right. In bidirectional shunts, when the systolic right to left duration is more than or equal to 30% of the cardiac cycle, it is considered non-physiological and very likely represent PPHN. If you see a right to left shunt, atrial shunt, make sure you rule out TAPPR until proven otherwise. Again, you can look at the tricuspid regurg, another easy way to do that. Use the Bernoulli equation, velocity square times 4 plus right atrial pressure. We typically use 5. We add to the calculation. So again, when you do an echo and the cardiologist is reading this, not a neonatologist, you need to let them know what the systolic blood pressure is so that they can tell you whether it's suprasystemic or subsystemic or systemic. So in this case, pulmonary artery systolic pressure is 104. Clearly, and blood pressure, 59 is systolic, 59 over 42, the mean of 48. You can also look at short axis and you look at the septum. This is a nice mitral valve with a rounded septum. Here is the septum is getting flat, almost looks like a D, letter D, or severe bowing of the septum into the left ventricle. Now, right ventricle is hugely dilated, right ventricle is very high. It's also going to decrease left ventricular filling and leads to decreased cardiac output. Okay, so what are the facts? I told you how to grade severe pulmonary hypertension, what causes hypoxemic respiratory failure. Now let's look at what are the factors that control pulmonary vascular tone under physiological conditions or under pathological conditions. Under physiological conditions, endogenously produced nitric oxide, which is eNOS, endothelium-derived nitric oxide synthase. Dr. Satyan talked about inducible nitric oxide synthase in baby sepsis that produces systemic vasodilation. But for pulmonary vasodilation, the critical enzyme is eNOS. There is endothelial cell injury, they may not have enough in eNOS activity. So L-arginine is converted to nitric oxide, and the byproduct is citrulline. Many years ago, people have used L-arginine infusion to treat babies with PPHN. Ganesh Ganduri and others published a paper. So once nitric oxide is formed, it diffuses from the endothelial cell into the adjacent vascular smooth muscle cell. Most important thing for nitric oxide to work is guanylate cyclase. Without it, no matter how much nitric oxide you have, you're not going to get a good response. So always think about nitric oxide guanylate cyclase as one system, as one molecule. Okay, so it acts on guanylate cyclase, converts guanosine triphosphate to cyclic GMP, which is the intracellular messenger that decreases the calcium concentration through phosphokinase, protein kinase A, and causes vasodilation. The second pathway is arachidonic acid pathway. PGI synthase acts on, converts into PGI2, and PGI2 acts on adenylates, combines with adenylate cyclase, converts ATP, adenosine triphosphate, to cyclic AMP. So both cyclic AMP and cyclic GMP will decrease intracellular calcium concentration, leading to vasodilation of smooth muscle cell. If you're not able to produce this, you can at least decrease the catabolism or breakdown of cyclic GMP using a phosphodiesterase PDE5 inhibitor. Sildenafil acts by inhibiting the action of PDE5, therefore cyclic GMP concentration stays high. To minimize the catabolism cyclic AMP, which is done by PDE3 to adenosine monophosphate, which is not an active compound. So milrinone blocks PDE3 activity. So either you can give nitric oxide or PGI2, or you can use sildenafil or milrinone, depending on the diagnosis. The other things are magnesium sulfate, which again blocks the calcium channel and decrease the calcium concentration in the cell, and thereby causes vasodilation. Recombinant superoxide dismutase, again, when the babies are getting too much oxygen, they produce a lot of reactive oxygen species. If we can scavenge them with the recombinant SOD, you can improve hypoxemic respiratory failure. Again, we don't have a compound like that to use. Many years ago, we used recombinant SOD to prevent BPD, but unfortunately, it didn't make a difference. 7 is hydrocortisone. Hydrocortisone acts like a PDE5 inhibitor. And I'll show you a number of mechanisms by which hydrocortisone acts as a vasodilator. Normoxia, by using saturation of somewhere between 90 to 96 or 95, will also decrease the formation of reactive oxygen species, which will downregulate nitric oxide synthase, decrease guanylyl cyclase production, and decreases PDE5 activity. The other drug we use is bosentan, which again, remember, endothelin-1 is a very potent vasoconstrictor. Not under physiological conditions, the balance between vasodilator and vasoconstrictors. In the fetal life, vasoconstrictors are very high. Postnatally, vasodilator concentration should go up once you start ventilating the baby. So endothelin-1, and bosentan acts on endothelin ETA receptor, which actually causes vasoconstriction, whereas endothelin receptor B promotes vasodilation. So typically, if you want to use it, bosentan as an endothelin receptor antagonist, usually used in chronic pulmonary hypertension. For example, babies with BPD who develop pulmonary hypertension. Diaphragmatic hernia babies now have pulmonary hypertension. Those babies, we use bosentan, which is again a oral formulation. So how do we approach the management? First thing is to minimize hyperoxia. You heard a lot about problems with high oxygen, nitric oxide, or combination of surfactant with nitric oxide. I'll tell you why we have to think about using nitric surfactant before we even give nitric oxide. Sildenafil in conditions, in countries, places where you don't have nitric oxide, sildenafil is a good alternative. Or you are trying to wean the baby off nitric oxide, then you could use sildenafil. Sometimes when you wean the baby, they get rebound pulmonary hypertension. You can start them on sildenafil and then wean the baby off from like 5 parts per million to 4, 3, 2, and 1. Hydrocortisone for pulmonary vasodilator resistant pulmonary hypertension. Milrinone, again, especially with the left ventricular failure, or so-called passive pulmonary hypertension, post-capillary or pulmonary venous hypertension. Milrinone is a very good drug. I recommend loading dose followed by infusion. I generally don't like to use loading dose. I just start an infusion. PGE1, prostin, 0.005 to 0.01 mg per kilo per minute. Some places PGI2 analogs are used, Flolane. IV infusion, very, very limited data. Most of them is inhaled, 50 nanograms per kilo per minute as Flolane inhalation. Bosentan, again, we only have oral formulation and 1 to 2 milligrams per kilo BID for chronic treatment of pulmonary hypertension, also CDH or BPD. Again, bosentan is metabolized by the liver, so we need to follow the liver function test. Think of oxygen as a drug. Oxygen is toxic. Titrate oxygen just like you would titrate dopamine or epinephrine or norepinephrine. We don't tend to do that. Always remember to tell the staff in the NICU that oxygen is a drug. You're using a drug. Let's wean the baby, at least below 60%, as Dr. Satyan said. What about, since we are not able to measure PaO2 all the time, it's intermittent, and most of the time, therapists will get the gas, everything suction, baby is stable, they get a good gas and show you, oh, the PaO2 is good. 2 minutes ago, that PaO2 is 30 or 40. So you really can't get a good idea about what the baby's oxygenation status is. That's why we use saturation. So this is a study by Tom Bachman and Prabhu Iyer from CHLA, from our division, looked at PaO2 over saturation. And they show that when the saturation by pulse oximeter is 99 to 100, SpO2 and PaO2, 243 samples. And the PaO2, the median, look at the interquartile range, 67 to 111. There is no way you can have a saturated 19 and 100 and say, I'm going to avoid hyperoxia. That's where Dr. Satyan said, no baby should be on supplemental oxygen. You see a saturation of 98. In my case, it will say 98 or even 97. I get worried about it. So 90 to 95, PaO2 median is 56, and the range, interquartile range is 50 to 64. So normoxemia, based on the PaO2, most people would agree, somewhere between 50 to 80 millimeters of mercury. Likelihood of hyperoxia is 45% when the saturation is between 96 to 98. Okay, so it's 97, that baby could be hyperoxic. 95% of the saturation is 99 to 100. Because the shape of the oxygen dissociation curve, risk for hyperoxemia increases exponentially when the saturation is more than 97. Same thing happens exponentially when the saturation is too low, below 80. Babies could be at very high risk for hypoxemia. So 86 to 89, you still have PaO2 around 50. This is term babies at a postmenstrual age greater than 36 weeks. So ideal target is 90 to 95. What about in preterm babies and term babies? So when they looked at it, again, you can see 90 to 95 saturation, nearly 3,000 paired samples of SaO2 and PaO2. The median PO to 63 in interquartile range 53 to 70. But you can clearly avoid hypoxemia by PaO2 or hyperoxia using a target of somewhere between 90 to 95. What happens in babies when you are cooling them on hypothermia treatment? This is what happens. Now, because the solubility of gas here, we use pH stat method. Most of you use hopefully pH stat method, where the blood gas is corrected to patient's actual temperature. So at lower temperature, the solubility of gas is increased, and therefore resulting in lower partial pressures of gas. So at 33 degrees centigrade Celsius, pH is 7.47, PCO is 32, PaO2 is 92. This is what babies' tissues are looking at. But if you take the blood from a cooling baby and heated it to 37 degrees in the blood gas machine, which all of them do, you're going to get a value of 7.40 and 40, and PaO2 is 112. So baby is actually hypocarbic and hyperoxic. So you really, oxygen dissolution curve shifts to the left, just like having a fetal hemoglobin. So in this case, maybe you accept a saturation of 90 to 97. So this is another recent paper looking at is oxygen saturation, does it work the same way in all babies? It's an elegant study from St. Louis. They looked at occult hypoxemia in black neonates, African-American neonates compared to white neonates. These are all babies less than 32 week gestational age, 124 dark-skinned babies, light-skinned babies, white babies, 170, nearly 4,400 saturation to SpO2 samples. And they showed occult hypoxemia. That is, when the SpO2 is more than 90, arterial blood saturation was less than 85 in nearly 9.2% of the time in black babies compared to 7.7%. So black infants have a higher saturation for a given arterial oxygen saturation, and this difference increases as saturation drops to 88 or 87. So if you accept an 85 saturation, for example, in a black baby, that baby is actually much more hypoxic because of the pigmentation effect on the pulse oximetry performance. Not only in newborn preterm babies, this has been shown in this, Dr. Satyan gave me this paper, and you can see that these are less than 17 years old, 1,000 babies, children, nearly 9,000 paired samples from Michigan, published in JAMA Network in March of this year. They showed that when the saturation, arterial saturation, blood gas saturation is less than 88, when the SpO2 is reading 92 to 96 happened, 13.4% of them white babies compared to 20, almost double. So what about in the Indian neonates with the different skin pigmentation? I think one of you should do this study looking at the effect of pulse oximetry and based on the pigmentation of the babies. So what are the recommended saturation targets? As Dr. Satyan said, there are no randomized controlled trials. These are all based on small studies, case reports, and expert opinion. They do not take into account reference to race, which we are recently coming to know about the impact of skin color, and blood transfusions. The baby gets transfused, you have adult hemoglobin, which shifts the curve to the right. So NRP, ILCOR recommendation, 85 to 95% by 10 minutes of age. Congenital CCHD screen, if the baby is 95 or greater, baby passes. And then the pre and post difference less than or equal to 3%, right? Hypoxemic respiratory with PPHN, most guidelines recommend 92 to 95 or 96. Diaphragmatic hernia, just heard from Dr. Satyan, 80 to 95%. BPD associated pulmonary vascular disease with hypertension, 90 to 95. The BPD consortium and European consensus guidelines. What about ROP? Phase 1, maybe 86 to 89. Phase 2, when the baby gets to 32 or 33 weeks, 91 to 95. Because early hyperoxia increase the risk for bad ROP. During hypothermia, maybe a little bit more, 1% or 2%, but instead of 90 to 95, 92 to 97, because the shift in the dissociation curve to the left. I have not seen any recommendation from any organization for targeting saturation more than 95 or 96 in newborn babies on supplemental oxygen. There's another paper published in 2006 by Chiavo et al. In relation to PaO2 of 50 to 75 millimeters of mercury, pulse oximeter saturation ranged from 95 to 98 before their blood transfusion, but decreased to 94 to 96 after the blood transfusion. So if the baby still has fetal hemoglobin, you may accept its saturation may be reading 95 to 98. So how does hydrocortisone work as a vasodilator? These are the 5 mechanisms that have been proposed based on preclinical studies, animal studies. Non-transcriminal activation of endothelium-derived nitric oxide synthase enzyme, increase in soluble guanylate cyclase activity. I told you nitric oxide has to combine with guanylate cyclase to convert GMP to cyclic GMP, increase cyclic GMP concentration, decreases PDE5 activity, just like sildenafil, and decrease the reactive oxygen species by increasing SOD activity. These are some of the mechanisms by which hydrocortisone can act as a vasodilator. What about surfactant? In a baby with meconium aspiration syndrome, if you give nitric oxide with alveolar atelectasis, you're not going to deliver the nitric oxide to collapsed alveoli. If you want to optimize ventilation perfusion mismatch, you need to recruit the alveoli by giving surfactant. In this study, this is the first randomized controlled trial published by from Chile, where after the study was published in the Journal of Perinatology, Dr. Ganesh Ganduri and Dr. Satyan wrote an editorial commentary, and they said this approach should now be the standard practice for neonates in hypoxemic respiratory failure and PPHN due to parenchymal lung disease like RDS, meconium aspiration syndrome. Here is the study. These are term babies, 38 and 39 weeks. They gave control just only with nitric oxide. Here, surfactant plus nitric oxide. They used poractant alpha, 100 milligram per kilo, and they showed similar birth weight, similar gestational age, baseline OI, very sick babies, 38, range 20 to 77. Again, mean 37. So when they gave surfactant and then gave nitric oxide, they improved the oxygenation, OI, and decreased the need for ECMO or death. So giving surfactant plus nitric oxide, ECMO or death was 16% compared to 36%. They also showed a non-significant towards less need for a second dose because the OI had come down below 20 after 6 to 12 hours after the first dose. What about vasopressin? Many of these with hypoxemic respiratory failure also have hypotension, systemic hypotension, either from LV dysfunction, vasodilator shock. So you want to use a drug to get the blood pressure up without increasing the pulmonary pressure. Most of the inotropes we use will also increase the pulmonary artery pressure. So you want a selective systemic vasoconstrictor. Vasopressin seems to do that. Again, very little experience in using vasopressin in hypoxemic respiratory and PPHN. Again, inhaled nitric oxide plus vasopressin, this is the dose used in some studies, 0.1 to 0.2 milliunits per kilo per minute, vasopressin ADH. So therefore, they may develop urinary retention, so dilutional hyponatremia. So you want to watch for sodium levels, decrease the fluid intake in anticipation of decreased urine output. What about CDH? There was a question one of the authors asked, one of the attendees asked last to Dr. Satyan, what are the recommendations, CDH consensus guidelines? This 2015 update, deliver at 39 weeks in a high volume tertiary center, don't paralyze the baby. I used to do that when I was a fellow or junior attending. That's what I was told to do that. Shouldn't be doing that anymore. Target a pre-ductal saturation. Yeah.
Very sorry to interrupt you. We have 5 more minutes to wind up this session.
Okay, then I will skip this. I think I'm almost done. Yeah, so if you're going to start nitric oxide, this is the rule that Dr. Satyan recommends. OI more than 20, use 20 parts per million, and response is PF ratio improves more than 20. Wean the FiO2 first after 60 minutes of starting, and the FiO2 is less than 60, and the PO2 is more than 60. I use 60, 60, 90 rule. So this is my last slide. Okay. Target pre-ductal saturation 92 to 96. Specify an upper limit of saturation. Don't say keep the saturation more than 95. That's a bad thing to do. Always specify an upper limit for saturation, which is 96 or 97. Hyperoxia acts like anti-nitric oxide, anti-sildenafil. Accept pre-ductal PaO2, 50 to 80, if we follow PaO2s. Avoid high FiO2. Dr. Satyan talked about it. We talked about INO plus surfactant, hydrocortisone. If you're going to use that, make sure baby is not septic, viral or bacterial sepsis. So thank you very much. And if you have any questions, here is my email. Feel free to write to me. Thank you for your attention. And thanks for the organizers for inviting me.
That was an excellent talk, Dr. Ramanathan. I do remember meeting you in Coimbatore about a few years back in a meeting when you spoke on surfactant therapy. Now, quickly, if you have any questions from the audience, otherwise I'll ask. I have a question. You did mention about the higher requirement of oxygen in hypothermia. When we do cooling therapy, do you recommend saturation target to be higher, 92 to 97, or should we wait for further studies on that?
No, I think, the difference between the pulse ox saturation when it's reading the difference between arterial saturation and oxygen saturation could be 3% bias. Therefore, to be on the safe side, you could accept, I'm talking about 1% more. So it's really not that critical. So it's still, you can use 92 to 96 or 92 to 97. But you want to get occasionally a PaO2 on PCO2 to make sure we are not over-ventilating the baby. Because if you are not using patient temperature corrected method, you may falsely keep these babies hypocarbic and hyperoxy.
Thank you very much.
Sir, regarding the early surfactant administration in lung parenchymal disease, sir, how we understand many times we encounter secondary PPHN much at 72 hours and later. So how delayed a surfactant can be decided on an NICU rounds? Can we go, right now we adopt until 48 hours even. What is your experience, sir?
I think the goal, if the baby is on supplemental oxygen, I'm assuming the baby is intubated, has meconium aspiration syndrome, the FiO2 is 40 and above, I would give him surfactant. I don't want the baby to declare respiratory failure. So I would give surfactant and get the oxygenation and decrease the need for nitric oxide. So 40% is what I use, but sometimes people may use 60% oxygen in an intubated baby. And you don't want to be close to 60% oxygen. You have the risk of reactive oxygen species in hyperoxia, lung injury, pulmonary hypertension, paradoxically pulmonary hypertension. So I would use 40% oxygen as a cutoff to give surfactant.
Is it same for all the diseases? For example, pneumonia also?
Yeah,
the same
yes, absolutely, yeah. I mean, sepsis, pneumonia, meconium aspiration, ARDS from whatever cause, COVID pneumonia, for example. Surfactant is now currently being evaluated as a treatment option in pediatric COVID-19 and neonatal also in Europe.
Thank you, sir.
Any further questions?
Yes, one more. So what is the rationale of using bosentan only in chronic PPHN, not in acute one?
Because we only have oral formulation and it takes time to act. And in a baby with acute pulmonary hypertension, I don't have any experience in using it, number one. Number two, Dr. Satyan is there, so he can comment on that. I have no experience in using in acute pulmonary hypertension. Most of the time, bosentan is sent as an outpatient. These are kids with bad CDH or bad BPD, go home on sildenafil and bosentan. Dr. Satyan?
I do agree with Dr. Ram. The only exception is babies with congenital diaphragmatic hernia, as you mentioned. So if you have a baby with bad CDH who continues to have severe pulmonary hypertension despite inhaled nitric oxide and sildenafil, then once you fix the hernia, if the baby is on at least 25% oral feeds, I start oral bosentan as long as the LFTs are normal. So that's the only indication where for acute pulmonary hypertension, I do use bosentan. But for the most part, as you mentioned, it's chronic BPD or chronic pulmonary hypertension in CDH. That's where you use it. Again, you have to check LFTs for sure and make sure baby is on at least some feeds, because otherwise you don't know if it's being absorbed or not.
Hello, sir. Thank you very much, Dr. Ram, for the enlightening lecture. I have a question as a corollary to the statement you had made earlier. It's gone.
I think they are closed. Okay. Is online? Okay.
Hello, sir.
Yeah, I'm here.
Yeah, sir. You were speaking about 40% FiO2 to give the surfactant just now. So if we are starting the baby on primary NIPPV, I mean, we might be able to reduce FiO2 at the expense of high PEEP. So what would be our approach in such a situation? Would we be still waiting for 40% if we think that baby is having RDS and the low FiO2 is secondary to the PEEP?
Most of the studies in preterm babies, they showed that, nasal CPAP, for example, fails when the FiO2 is more than 30%. So the European guidelines have changed from 40 to 30%. A baby is on nasal CPAP of 6, from 5 they went to 6, and the FiO2 is 30% or greater, chances are babies are going to fail nasal CPAP. That has been shown by 3 large retrospective studies, one by Peter Dargewel, one from Poland, third one from Texas by Kakilaya Venkatesh et al. So in bigger babies, meconium aspiration babies, not that sick enough to be intubated, you're able to manage an NIPPV, and the FiO2 is 50% or so, I would probably go ahead and give surfactant. I'm still more careful. I don't want the baby to get into PPHN. I don't want to go up escalating use of nitric oxide or sildenafil. So I would go ahead and give surfactant, get the VQ mismatch.
My question was if the baby was on primary NIPPV.
Term baby or preterm baby?
Preterm baby on primary NIPPV.
Preterm or term baby?
Preterm.
Preterm, yeah. Preterm, the FiO2 is more than 40%. I would give surfactant, yes, for RDS.
Even if baby is on high NIPPV settings, like
yeah. The FiO2 and the PEEP are 2 different issues. If you're on high PEEP because you're trying to keep the lung open, you can give surfactant and wean the PEEP so that you don't have any adverse effect, hemodynamic effects of high PEEP. But looks like if the lung is collapsed, the pulmonary pressure is going to go up, right? If the lung is open, a hyperinflated pulmonary pressure is going to go up. It's a U-shaped curve. So you want to, even if the baby is an NIPPV and you are needing higher PEEP, higher pressures to recruit the lung, it's a good idea to give surfactant. You'll be able to wean the pressures, NIPPV.
Okay, sir. Thank you very much.
So good morning. One last question, sir. What is your take on surfactant in a black lung PPHN where there is no lung pathology per se?
No indication as far as I know, because if we give surfactant, actually we may make it worse. The baby can go into severe PPHN or becomes very labile. There's no indication to use in a black lung, so-called the PFC syndrome, due to abnormal transition or reactivity. That's a good case to use nitric oxide or vasodilator. They respond very well.
Thank you.
Hi, sir. This is Dr. Ramanathan from Vijayawada. Thanks for your excellent talk, sir. Prof. Very informative. So my question to you is, in neonatal cardiac surgeries, we do cardiac surgeries in our center. What about using sildenafil or hydrocortisone in babies who are stuck on, of course, ventilation and giving nitric and sildenafil?
I mean, these babies, you're talking about immediate post-cardiac, like a PDA ligation syndrome or post-cardiac surgery, they fall apart because the relative adrenaline insufficiency, even in a term baby. Yeah, we would use, if they're already needing inotropes or vasopressors, then I would use hydrocortisone in those babies, as long as I'm not worried about sepsis. Yeah.
Thank you, Prof.
Thank you very much, Professor Ramanathan.
Thank you for great questions. Okay. All the best.
I would take this opportunity to thank the organizers for giving me this opportunity, especially Dr. Manoj and Dr. Vishnu. Thank you all.
We are so grateful to you for this informative session, Professor Ranganathan Ramaswamy. Thank you for joining us. We also thank you, Dr. A.R. Srinivasan, for your guidance.